Welcome, everybody. Again, my name is Schendowich. I'm a Hematology and Oncology Fellow at Georgetown. Today, we're going to be appraising the ArteraAI multimodal AI breast cancer prognostic model. The goal is to understand what the model predicts, how it generates a distant metastatic risk score, and whether the evidence supports using that score in clinical decision making. I want to start with the clinical problem. In hormone-positive, HER2-negative early breast cancer, it is the most common form of breast cancer, and the recurrence risk varies substantially across patients. Some patients have very indolent disease, while others eventually develop distant metastatic disease despite the standard of care therapy. So the clinical gap is relatively straightforward. Can we more accurately identify which patients are most likely to recur? The intended goal of this model is to predict distant metastasis risk by combining clinical features with information extracted from histology slides. Below is an example of a sample cancer test report from ArteraAI that you might receive in the clinic when you order this specific test. Now that we've defined the clinical gap, this slide shows where the AI biomarker could fit in to the broader treatment framework for localized breast cancer. Localized disease is categorized by the biologic subtypes. So you have hormone-positive disease, you have HER2-positive disease, and you have triple-negative disease. This model is focused specifically on hormone-positive disease, HER2-negative early breast cancer. In this setting, adjuvant treatment decisions are already dependent upon several sources of information, such as the genomic assays like Oncotype, mammoprint, histologic features such as grade and proliferation, and clinical features like the tumor size, nodal status, and menopausal status. The AI biomarker that is being proposed acts as another risk stratification tool. So before we evaluate the model, I want to anchor this to a clinical case. So this is a 55-year-old postmenopausal woman, female, with hormone-positive HER2-negative early breast cancer. She has a small 3 mm grade 2 tumor with one positive lymph node and an Oncotype recurrence score of 26. Based on standard features, many of us would be thinking about adjuvant chemotherapy, followed by endocrine therapy. However, when we order the ArteraAI breast multimodal prognostic score, it comes back as low. So the question is what do we do with this information, and can we trust it? I'm not going to answer that right now. I'm going to come back to that at the end of this presentation, but I want you to think about whether the evidence that I present to you support guiding any of your treatment decisions. So now I want to review the model structure. And there's two parallel pathways. The top pathway is the image pathway. And this involves pre-treatment histology slides that are processed through self-supervised learning and multiple instance learning to generate an image-based distant metastasis risk signal. The bottom pathway is the clinical pathway. It uses a Cox proportional hazard model that analyzes standard clinical risks such as age, tumor size, T stage, and end stage. Those two outputs are then combined in a late fusion step, producing the final multimodal AI prediction for distant metastasis. Again, the key point is that this is a multimodal prognostic model. Both the images and the clinical inputs are what makes this multimodal. We're going to break down the model into 4 specific steps. And I want to start with the first one, and that's really preparing the pathology slides. The pathology slides is converted into small image tiles. The model first digitizes them, removes the non-tissue background structures, and then splits the tissue into patches for downstream feature learning. In step 2, the model learns the patterns that are present on the histology slide. It is not being taught specific pathology labels. Instead, a CNN, which is a convolutional neural network, is trained on the patches using self-supervised learning. This is a way to train an AI model without needing humans to label each image. It learns by comparing different versions of patches and identifying visual similarities, much like the grouping of cats and dogs below. We're going to call this contrastive learning, or that's what it's called. The result of this is that each patch becomes a numerical embedding, and these embeddings may contain prognostic information, but we cannot directly translate them into what we understand as classic histologic features. After the CNN converts the patch into numerical features, the number needs to summarize all of those patches from a patient's slide. This is where multiple instance learning comes into play. MIL treats the slide as a bag of many different patches, learns which patches carry the most information about distant metastasis risk, and combines them into one continuous image-based risk score. The model has two pathways. It's multimodal. And so that means that they are combined late, and it's a late fusion into a final 0 to 100 multimodal AI score. However, there's certain elements that remain hidden, and one of them is the patient-level reasoning. We don't know which histologic features drove the image score, whether those features map onto known pathology patterns, and why a specific patient received a specific risk estimate. The published model description also does not report common AI guardrails, such as saliency maps or uncertainty estimates and no-call rules. These are all guardrails that certain AI models may use to help prevent clinical risk when it is used in practice. So now let's discuss how the model was trained and the population it was trained upon. So they used two specific trials, the PlanB trial and the ADAPT trial. The cohort was split into a 60-40 split, meaning that 60% of the people were used for model training and 40% was used for internal validation. That's about 3,167 patients for development, 1,995 patients for internal validation. The design of the training trials is important because when interpreting whether the model is purely prognostic or partially reflects outcomes shaped by treatment assignment. So let's look at these two specific trials, the PlanB and the ADAPT trial. Both of them used recurrence score, that's oncotype recurrence score, and clinical features to guide the interventions. This matters because the model learns distant metastasis risk within the treatment-guided trial population rather than an untreated or randomized natural history cohort. And what this leads to is the central causal issue that I want to discuss or highlight. And that's that the oncotype recurrence score was not an input into the model, but it did influence treatment assignment within those trials. Since treatment then affects distant metastasis, the outcome the model is trained to predict is not untreated recurrence risk. It is observed distant metastasis risk after the oncotype-guided treatment. So what does this mean practically? It means that if you have a high multimodal AI risk score, that may be because of aggressive biology, or it may be because this patient is undertreated. Conversely, if you have a low multimodal AI score, that may be because it is an indolent tumor, or it may be because chemotherapy may have prevented distant metastasis. So you don't know exactly why or what the multimodal AI score is representing. Now let's look at the performance, and specifically the internal validation cohort that was stratified by the multimodal AI score. So the patients were ranked by score and grouped into binned deciles, so that's 10%. The key point is that these curves separate over time. The lowest scored deciles, 1 through 4, had about a 2% 5-year distant metastasis risk, while the highest decile had about a 19% at 5 years. So the model is not just statistically associated with distant metastasis, it creates a risk separation. And you can see that there's quite clear separation of these curves over time. Now, let's discuss the model's subgroup performance. Here are two examples. The one on the left is the premenopausal patients, and the one on the right is the patients who received chemotherapy. The key point is that even within these groups, the curves still separate. So the model is not only separating the entire validation cohort, it appears to add prognostic information within groups that oncologists already think about clinically. The previous slide showed the absolute risk separation within the selected subgroups. This forest plot shows the same conceptual statistically, or same concept statistically across a broader set of clinical groups. The main takeaway is that the score is consistently prognostic across several different subgroups that were described here below. Now, I want to talk a little bit about the appraisal domains, and that's what this slide summarizes. And I want you to keep it in context because the clinical goal is a prognostic risk stratification for distant metastasis, specifically in the hormone-positive early breast cancer population. The main strength is that it fused the fused multimodal AI score was prognostic in the internal validation among several clinically relevant subgroups, including the image score alone. And that's what I highlighted here in orange, meaning that the image score alone was also clinically relevant in separating the cohort's risk. But there are several limitations to the model. And the first is generalizability. And, this was done in two specific populations, and it was done in two German-led clinical trials. It is unknown if this can be generalizable to a whole diverse population such as the United States. So this was a retrospective development with only internal validation. They did not mention any external validation within the original paper. Second is that there was only 96 metastatic events in the final validation cohorts. That's not a lot. And so, you're considering a lot of variables in predicting an event that doesn't happen that frequently. The third is that the oncotype recurrence score cannot really be used as an unbiased comparator because it influenced the treatment assignment within the source trials or the trials in which the model was trained upon. So what does this mean? So, when you take it all together, my overall appraisal, when you consider all of these variables, is that it is a very promising prognostic model, but it is not ready for the clinic. It supports risk stratification, but it does not necessarily address the more relevant question of treatment escalation or de-escalation. And that's kind of where the paper that I sent you guys ends and where the follow-up evidence begins. So at the San Antonio Breast Conference Symposium in 2025, there was new data presented that strengthened the prognostic validation story for this ArteraAI breast multimodal model. First, specifically in the B14 and B39 trial cohorts, the model appeared to improve 10-year distant metastatic prediction beyond clinical comparators. But again, this was not directly compared to Oncotype DX or recurrence scores. This addresses the concern of external validation. Next, the ABCSG8 trial cohort was particularly useful because it evaluated prognosis in an endocrine therapy only cohort. So that provided a clear prognostic validation setting because the outcomes were not mixed with chemotherapy exposure. And finally, and maybe most interestingly, the B20 trial cohort was the most clinically relevant because it began to address whether the model can function as a predictive biomarker. Overall, the biomarker did not significantly predict chemotherapy benefit, but there was an exploratory signal in those above 50. And, although it was promising, I would still treat this as hypothesis generating. And so again, this does not change any of the clinical discussion we had before, where this model is still a prognostic model. It does not show clinical use in predicting treatment escalation or de-escalation at this point in time. And the key points to this, or the key weaknesses, is that there's no head-to-head comparison versus Oncotype DX or MammaPrint. There's no prospective model-guided trial or evidence to suggest that it could be used for treatment de-escalation or escalation. And the image component remains black box with no interpretability improvements reported and minimal clinical guidelines, or not guidelines, but guardrails in place to prevent, poor outcomes when used in clinical practice. So let's come back to the case. Let's come back to this patient who has a node-positive, hormone-positive disease with an oncotype of 26. Although the ArteraAI report shows a low prognostic risk, I would not use it to de-escalate any therapy. Again, that's not what they're claiming the model should do, but regardless, it should not be used in that setting without appropriate evidence and clinical guardrails. The model stratifies distant metastatic risk, but it has not been prospectively proven to identify patients who can safely omit chemotherapy. And with that, I want to open this up to a discussion and questions specifically about the model, some of the problems with the model, and some of the potential future opportunities of this specific model.